Welcome to our video on improving services during the pandemic using digital transformation. I'm Lisa Hollins, I'm Director of Innovation for NHSX, and I'm going to introduce you to my colleagues. Firstly, we'll hear from Matthew Gould, the Chief Exec of NHSX, who's going to talk you through the broad transformations and improvements we made during the pandemic. Then I'm going to hand you over to Andrew Wilkinson, who's going to talk about virtual consultations in hospitals across the country in England. And then finally, myself and my colleague, Chris Richmond, will talk you through the treatment of COVID patients and long-term conditions using remote consultations. So we hope you enjoy the video. We've enjoyed sharing our work and we look forward to connecting with you in future. Thank you.
I'm the Chief Executive of NHSX and the National Director for Digital Transformation of NHS England. NHSX is the digital transformation arm of the NHS. It's our job to drive transformation in the NHS and social care using digital technology. And over the past year, through the pandemic, we've seen an extraordinary shift to digital channels, digital ways of working. And it's been the use of digital technology that's been one of the key ways that the NHS has been able to continue to offer the service and care to our citizens that it has been able to. So we've seen an extraordinary shift in consultations, for example, from in-person to online. At the start of 2020, we reckon about 3% of GP surgeries were enabled for online consultations. By the end of the year, it was 99%. We've seen a huge number of clinicians and non-clinical members of staff working from home rather than having to go into formal care settings. We've seen remote monitoring of patients take off in a really big way. My team has set up almost 100 virtual COVID wards where patients were given pulse oximeters linked to a digital platform so they can be monitored while they remain at home out of the lower risk of infection. So the last year has seen enormous progress, an enormous shift to digital. But we've got our work cut out to build on that, to lock in that progress and to turn it into genuine transformation so that we properly make use of the potential of digital technology to reimagine how care is given rather than just do the same thing but online. And the work of NHSX really divides into 4 areas. I mean, number one is fundamental, which is digitize. If we want the health service, if we want social care to make use of digital technology, then they can't be operating on paper. And we still have trusts, we still have a lot of the care sector which does. So task number one is to digitize the NHS, or finish digitizing the NHS and social care. Task number 2 is connect. It's making sure that patient data can safely, appropriately flow between care settings. And one of the lessons of the pandemic has been that getting patient data to flow, to move with the patient, whether it's between different bits of the NHS or from hospitals to care homes or vice versa, is absolutely critical to patient safety and getting the best patient outcomes. And one of the things my team did during the pandemic was make sure that that data could flow. We put out really simple, empowering guidance on information governance so that clinicians could share data with confidence, knowing that it was legal and appropriate. We put much more data in the summary care records that clinicians can pull up about the patients in front of them so that they knew the salient facts around them. We made it easier for data to flow between the NHS and social care. So 1, digitize, 2, connect, 3, transform. And for me, this is where it gets most exciting of all, where you use the internet and the possibilities of digital technology to rethink how care is given. So, for example, the model of having to go to see your GP, the GP sending you in to see a consultant, you going up to the hospital, then you going up if you've got a long-term condition every 3 months or 6 months afterwards to get those things measured. That we can improve that with care at home, with remote monitoring, with remote consultations, with online triage. There are tools at our disposal now that are proven to help clinicians, to help the NHS improve outcomes, provide a better, safer service to our citizens. And we've been working with colleagues in the Royal Colleges, the National Clinical Directors, to rethink how care pathways for different conditions work, so that we can really make use of the potential of digital technology to improve them. And then underpinning all of that is the system change that's needed to make sure that it's easy in a sort of complex, distributed, vast system that is the NHS and social care to do the right thing. So we're providing our What Good Looks Like guidance coming out soon, which sets out criteria for a good performance in digital transformation, setting out clear guidance on information governance, setting out clear guidance on funding. So if you're the chief exec of a trust or the head of a system, you know what it is you need to be paying for out of your own budget. We're putting a real investment into the workforce and skills so that we have confident, digitally savvy people who aren't necessarily experts, but whether they're the chief executive of a mental health trust or an A&E doctor, they have the confidence to engage with the digital technology and the data to make best use of it. So you'll hear more from my colleagues now, but we've had an extremely busy year. We've worked fantastically closely with colleagues across the NHS and social care. A vast amount has changed in the past year, and we've got a real opportunity now to drive transformation in a really profound way that has massive potential to improve the care we give our citizens.
Thank you, Matthew. I'll now hand you over to Andrew Wilkinson, who will outline the transformation of virtual consultations in secondary care. Over to you, Andrew.
Hello, I'm the Director of the National Outpatient Transformation Programme at NHS England and NHS Improvement. I'm here today to talk to you a bit about how the health service in England undertook one of the biggest changes in outpatient care delivery in a century through the COVID-19 pandemic, and that is the shift to virtual delivery of around about a third of all outpatient care. The change was driven partly by a shift to video technology, but also a dramatic increase in the use of telephone consultations too. If you look back to 2019-2020, around about 4% of all outpatient attendances were delivered by telephone or video in that year. And the NHS had got a plan pre-pandemic to avoid the need for unnecessary trips into hospital for face-to-face attendances and avoid about a third of those over time by 2023-24. Clearly, what happened next was to surpass that goal by some way in 2020. We can see here the story about what happened. So to explain the chart a little bit, the grey area at the top is outpatient attendances with a procedure. The blue are face-to-face outpatient attendances, and the orange are virtual outpatient attendances. So that's telephone or video. And as you can see, with the impact of the pandemic and the efforts that have been made by NHS organisations across the country, there was a significant and lasting shift in the way that outpatient care was delivered. Across the year, in 2020-21, we had 3 million video consultations on a nationally procured platform, which I'll talk about in a second, as well as 1.5 million video consultations on other platforms and more than 15 million telephone consultations for patients. That was a significant change in the way that patients access high quality care. And the benefits that arose to patients were considerable over and above the access to healthcare, which of course was continued through the pandemic. Based just on the attendances avoided between April and February, so when we have data for, we avoided patient travel into hospital based on the average journey time, equivalent to 531 million miles of travel. That's the equivalent of travelling around the world 21,000 times. That is a significant benefit to individuals who are not taking time off work or school. That's 1,300 years of patient travel time if you add it all up together. But it's also helpful for the environment. So 108,000 tonnes of carbon dioxide avoided from the emissions of those hospital journeys. And we also freed up pressure on hospital car parks. Now, this is, of course, not the primary purpose of the health service, but it is really important that we make our services as convenient as they can be for those who can access high quality services in this method. And one of the particular benefits of delivering this through such a difficult year for the NHS in terms of the pandemic was that it slightly lessened the pressure on personal protective equipment in hospital settings, because outpatient care could still be delivered without patients on site, and it enabled a bit more flexibility for clinicians who clearly were facing several demands and pressures on their time. Of course, none of this is worthwhile if the quality of care is not high, and we do a pretty intensive evaluation to make sure that we're tracking the impact of remote care. And nobody would say that remote care is appropriate for all people in all situations. There will be differences in terms of individual preference, in terms of digital literacy or connectivity, in terms of the type of care that's being delivered and the clinical circumstances. So whether or not it requires the laying on of hands or not. And we know, though, that there are many follow-up attendances where virtual appointment can be very effective and very beneficial for all concerned. You'll see on the slide that there are a range of evaluations that have been taking place across the NHS during the last year to pick up on staff feedback about the experience of delivering remote outpatient care, as well as individual patient feedback. And as you'll see, there is usually 8 or 9 in 10 people feeding back that they thought that the experience was very good or good. And that is really important. We need to make sure we keep measuring that, and we need to make sure we continue to press for further improvements in the way that care is delivered. But it is a good start in terms of the studies to date. So how did that happen, and what happened across NHS England, NHS Improvement, NHSX and local health organisations? Well, we took a really rapid approach around about last March and April, when the first wave of the pandemic was affecting England, to make sure that we scaled out video consultations to every single hospital in England. We had a really rapid pace to do that. We had been piloting a study for 12 hospitals to use video consultation, and we used the learning from that small pilot to do a really rapid scale up to the whole country. There was a regular battle rhythm of meetings between the national team, regionally based teams and local teams in every bit of the country to make sure that we had a really good feedback loop on what was happening day by day in the rollout of video technology. We made sure that we simplified the ask. So if there were things that we could do nationally, such as procuring a video platform for use, we did that once nationally. And if there are things that needed to be done on a more local level, we did as much of the legwork as we could by pre-populating templates, by putting in place data protection and data sharing agreements, and making sure that what we were asking for was easy to understand and easy to implement in the context of very, very pressured health services at the beginning of the pandemic. We shared support between different areas to make sure that where progress had been made in one part of the country, others could learn from it. And we made sure that we were always accessible to be on hand to help with technical queries, with logistical queries, or with any other requirements that might come forward from such a rapid piece of work. We also had some key considerations in mind. So we were conscious of digital inclusion and of the potential cost of video consultations. So we managed to strike agreements working across government to get free 4G data from some of the major telephone networks for video consultations, so that patients wouldn't be charged for the data they used in accessing healthcare services. We made sure that we focused on inequalities and made sure that we did as much as we could to reduce health inequalities. There's further studies to do on that and further work that we need to do to always get better at closing the health inequalities gap. But we are fairly confident that some of the impact of what we've done in avoiding the need for bus fares to and from hospital or time off from work or school will have a positive impact on some health inequalities in the country. We made sure we focused on optionality. This was never intended to be a one-size-fits-all. Remote consultations, as I said, are not appropriate for absolutely everyone, but to have the option there for those patients for whom it would be a successful way of receiving health services was really important. So optionality has always been and will continue to be a key priority and a key principle. We've also shifted through April 2021 to locally arranged provision for video consultations. And the movement from a big national arrangement into local arrangements is part of the maturing of video consultation in the NHS. And we've also made available advice from leading clinicians about how best to use remote care for different conditions within specialties, because that optimization of the way that you deliver remote care is a really important part of making sure we do it right. So what's next for the delivery of mainstream remote outpatient attendances? Well, the option of a video or a telephone call for your hospital appointment is very much here to stay, but we've got more to do to catch up with, if you like, the rapid and fairly organic growth of remote consultations in England. We need to make sure that we are analysing and evaluating whether it's good practice and whether it's poor practice. What that means is, if there are some conditions where remote consultations would seem to be appropriate, but potentially lead to higher referral rates for tests, clearly overall that's not a benefit to the individual or to the health service. So we need to put in place guidance to make sure that works in a better way. Equally, there might be areas where remote consultations are not undertaken at the moment at the scale that would be optimal, but we need to put in place guidance on that as well. So we're going to be out there helping with clinical leadership to the front line to make sure that we deliver remote care in the right way for the right people. We need to continue to measure the equalities impact of everything that we do and make adjustments if there's any areas of concern. We need to measure the patient and the staff experience to make sure that any technical issues are picked up on, but also the sense of fatigue or any training implications for the new workforce, that we pick up on those and we help to counter them and make them fix any issues that arise. And we need to have a full, broad communications campaign for patients and the public, as well as for health service staff, to be clear that remote consultations are not a temporary measure that came in through the pandemic, but are definitely part of a modern health service, being flexible for the needs of patients, offering options for those for whom it's a good option, but also having traditional services there ready for anyone for whom that's appropriate. I'm really proud of the work that the NHS did last year in mainstreaming remote consultations for patients, and really, really proud of the feedback that generated from patients and the front line. And I'm looking forward to the next steps on making sure it works even better into the future.
Thank you, Andrew. So I'm going to take you through the next area of change and introduce remote monitoring. So remote monitoring works by connecting the patients to the clinical teams and having remote monitoring devices at home, such as pulse oximeters, having those attached to platforms which can transfer that information from the patient to the clinical team. The clinical teams can then remotely have a look at that patient data and see if the patient's on track or they're deteriorating, and then they can take action if they need to. So this is a really good way of monitoring patients at home, highlighting if a patient is deteriorating, and making sure that we only have patients in hospital when we need to. And we used this extensively during COVID, and I'm going to hand you over to my colleague Chris Richmond, who's going to tell you about all the work we did during the first wave of the pandemic. I'll hand over to you now, Chris.
So we started with remote monitoring in a virtual ward in Watford. This was a real world problem that was met by a real world need by a consultant in Watford who contacted Matthew Gould late on a Sunday evening to ask for help. They were already running a patient pathway for a virtual ward with no technology involved. It was complex and the ward was fast running out of capacity. It was a cry of help to see if there was anything that NHSX could do to support them in their care for the patients in their area. To do this, we identified a product and we did a bit of matchmaking. We didn't force the product on them. We identified something which may be helpful and asked them if this would meet their need. The patient was at the front of this. The app was already in use. It wasn't a new app. It was a product that would be widely used for monitoring long-term conditions. And it follows a similar pathway to the COVID oximetry at home pathway they were using. So that was quite useful as well, in the sense that it could be put into the pathway and to meet their clinical need. Working at the diagnosis, the patient would be identified, and when they attended the virtual ward or identified with COVID, they were given instructions on how to onboard into the product. This was given by a consultant or somebody within the team in the hospital who ensured that the patient was happy to do this. At all times, they're also running the pathway, which was a non-technology enabled pathway as well. So there's choices for the patients, picking up on the point that Andrew and Matthew have made, and Masood has made around there being patient choice throughout this. It wasn't mandated they had to use this pathway. They were also shown how to input data into this very basic product from a pulse oximeter, which was also supplied to them. This could ensure that they could take their readings 3 times a day. Previously, this had been done, and on the other pathway, this was done by 3 phone calls a day in the first instance, and then phone calls on 1, 3, 5, 7, 9, 11, and 14 days. As you can see, using technology made this much easier because there was no telephone contact required with the patient unless there was a clinical need for that or to check in with the patient for other reasons. Again, this was an extension of the human rather than forcing technology onto somebody. The data was fed back into the clinical dashboard for the clinician to see, where it was looked at on a daily basis by a range of clinicians, pathophysiologists, physiotherapists, consultants, respiratory surgeons, even a consultant cardiologist who was working from home because isolation due to COVID was able to do this. If necessary, a consultation could be undertaken from within the product, a video consultation. What we found was a lot of people liked the video consultation. What they also liked was the fact that the consultant could check their observations by getting 2 ticks within the system. So they were assured that somebody was looking after them. Then after the 14 days, if appropriate, the patient would be discharged from the product. So that's how the patient pathway worked. From a clinician's point of view, as you can see, it follows the same outline. There was a unique code. So there's some admin support required at that time. So there's admin support so you can get it into the clinical system. At that time, there was no interoperability because this was a rapid rollout of a product. There was no interoperability with the clinical system that was in use. So there was some double entry required. So there's some admin time required there to get the NHS number and to ensure that it could be linked to the clinical records at a later date for patient safety. The clinician could see any entries in real time. This was very important because it flagged up where somebody had made entries, but also equally important was you could see where patients hadn't made an entry and you could make contact with them if you needed to. The dashboard RAG rated the patients as well. So if somebody had entered observations which were outside of the parameters set by the site, because the clinicians set the clinical pathway on this was done by negotiation and understanding of what was the best practice at that time in COVID. And again, as I've said previously, the clinician could also video contact them and then they could be discharged from the system, and where all of that data would be then transferred into the clinical system via manual entry. So there's lots of things that happened around this. So as I've already mentioned, this was a real world problem. This was, something that needed to happen. The ward was fast going to run out of capacity. We saw virtual wards popping up. There was a virtual, and at the same time as I was doing the project in Watford, there was also virtual wards in Northwest London, which was starting to work. So we had primary and secondary care models that were running at the same time. So it was very important that we got these off the ground very quickly. We managed to do this from the first phone call to getting the first patient on board in the secondary care site in 4 weeks. This is unheard of, and there's a lot of time from Lisa and myself to do this, and lots of issues around IG and working with the organisations to help overcome some of the issues. What we identified was there's probably lots of learning we could take from this for other sites. So we did a global digital exemplar blueprint, which helped to do this, which has since subsequently been used, as Matthew mentioned, to roll out into the 92 sites that have supported this. This gave us a background so we can actually extend ourselves and people could take the learning from those other sites and apply the learning, iterate it to make it necessary for their sites across primary and secondary care. We did start off with a stretch target. We thought if we could get to 50 technology supported sites, that would be a real achievement. We actually got, as I mentioned, got to 92 sites, which was a real achievement. And we know that over 8,000 people have been supported through technology in these sites. Just some information. So obviously this is all done and implemented without using formal improvement science or improvement methodologies to do this. Improvement methodologies were followed and there was a clinical need to do this. We had the stakeholders on board at the site so that they came to us with a clinical problem. What they did was they identified the metrics they wanted to measure. So obviously patient admission data was part of that, the quality and the safety of the intervention. So what was the mortality rates potentially from one cohort to another. So they did apply the principles of improvement science to the rollout without doing them formally. One of the big measures, and again it's been touched on by Masood and Andrew, is that there's a potential time saving here. We don't do these things to save times, but actually in using this product, for every 100 patients in the virtual ward, it was calculated that around 1 full-time equivalent of consultant time was saved. That meant that that patient could be managed remotely, but also it means that that consultant's time could be used to conduct consultations with the other patients who were unable to access, maintaining the equity of service for all those patients and ensuring that they all got seen within a timely manner. I think there's lots of learning we can take from that. So it was key to this was patient safety. You know, patient safety, clinician safety were all key to these. The outputs from this have been used widely. They are informing our decisions going forward of how we may implement technology, how we need to use improvement science to help implementation, to make implementation sustainable. The important thing is that we had good feedback from patients. The patient stories that we've got from this to help support this, so we've got some really good qualitative inputs that we can use with products going forward and what clinicians want to use. There are a number of empirical publications that are going to come out of this work as well. Some have already made it to press by peer review, but there's lots of other empirical evidence that can be developed from this to help build the cadre of evidence for remote monitoring. Admittedly, at a time of COVID crisis, it can be used elsewhere. I'll hand back to Lisa.
I'm just going to say a few words about what happened next in terms of the work. What you've heard is that we rapidly developed COVID virtual wards for patients, and we had an overwhelming response from our hospitals that they wanted to know about all the digital innovations that were out there. So this is what we did. We produced 5 digital playbooks for a range of clinical specialties, where people could see all of the multitude of digital innovations that were there. And these were aligned across the clinical pathway. You can see the cardiac pathway here, and these are all available on the NHSX website, so do have a look. And the next area of change, we want to try and understand how we can quite fundamentally change the way we care for patients. Previously, we've seen healthcare always organised around visit-based care. We want to change that quite fundamentally, and you've seen how some of the technologies can do that. We can make sure that even caring for a patient in their own home, we can have a look at the supporting them, monitoring their vital signs and intervening really quickly. And what we need to do that is to address some of the technical barriers of connectivity, which we've started to do, to create those really transformational pathways, working very closely with clinical teams. We've given you some examples of COVID, but also cardiology, respiratory, ophthalmology, dermatology. Most specialties can be aligned to this way of working. We need to make sure that we really support patients with long-term conditions, because we know that they visit hospital the most, and we can make sure that they're supported mostly at home. And we can also make sure that patients know when they're deteriorating and when they can help themselves through looking at how they can exercise or diet, or all the tips and techniques to support their own care. And I think the final thing that we're looking at is how we can make sure that we can adapt diagnostics. We've given you some examples of really small devices, which are 2 inches, that can stay within a patient's home. And we're going to have a look at some of the more larger, more fundamental diagnostics and see if we can adapt those and make sure we can care for more people. So that's the future of healthcare. We have made a whole range of changes which link to the improvement methodologies that I know people are really familiar with. I think the first thing to say that we adopted this at pace, and we really used the PDSA small cycles of change. This was really important for us, and we certainly were really adaptive. We made changes, worked really closely with the clinical teams to do that. The second improvement area was to look at measurement for improvement. So looking at how many patients were using the technologies, what they liked about that, and getting some real frontline feedback from patients was used. And we used all of the SPC metrics for measurement for improvement. We also made sure that we worked so closely with the clinical teams. Of course, in many cases, we had to do this virtually because of the contagious nature of the pandemic. But we used the Gemba methodology of really understanding from the front line what their problem was and how we could solve it. And finally, we created a whole range of energy and excitement and celebrated success. So we're really creating a social movement. And Chris mentioned the Innovation Collaborative, which holds the whole range of case studies. There are case studies on the digital playbooks, and we're joining with our NHS staff to make sure we can transform care using technology. I hope you've enjoyed our video. We've been thrilled to present to you today, and do visit our websites if you need more information. Thank you.